For a number of years in Canada, and then came down for about the past half dozen years. She's been in the United States, where she is currently practicing. She's also consulted for a number of companies on metabolomic and multi-omic technologies. And she's currently at Altum Medical, which is a practice that provides really a deep dive into functional medicine care. She is the founder of Medical Intelligence Learning Labs, which is a company that tries to create a platform, or has created a platform, that works to enable clinicians' clinical experience to be brought together so that a larger medical community can access that. So with that, I will turn it over to Dr. Helen Messier.
So thanks, Dan, for that wonderful introduction. And it's really nice to be here with you, unfortunately, in our virtual world, but it's wonderful to be here anyway. And today we get to talk about food, so I know you're all coming back from lunch. As we go through this talk, just kind of think about the lunch you had and see if it was inflammatory or anti-inflammatory. And it'll be fun to kind of go through that. There is a reason that we put the dietary prescription at the beginning of this program. It's really a fundamental intervention that you have to consider in every single patient with either an inflammatory or an autoimmune condition. If you don't assess and address the diet in your patients, you will be missing the foundation. So our objectives are to review the nutritional interventions that can be used for both chronic inflammation and then those interventions that we can use for autoimmune disease. And at the end, the goal is to be able to compose a diet for your patients that will address inflammation and autoimmune disease. So clearly we know that all of these different diseases, from Alzheimer's to diabetes to arthritis, colitis, eczema, they're distinct entities, but underlying all of these is the etiology of inflammation. So there's a pro-inflammatory state that really drives all of these different conditions. And in a majority of these cases, diet is the antecedent, the trigger, or the mediator of inflammation, and sometimes it's all three. So even though different diseases may require different treatments, the base of all treatment programs really has to address diet. So both by removing the inflammatory foods and then adding the foods in that decrease inflammation and autoimmunity. So chronic inflammation presents in many different ways. Let's look at one of the ways it can present. Now this is Rachel. She's probably someone you've all seen in your practice. Rachel's a 53-year-old lady. And she just had an appointment with the rheumatologist because she was experiencing joint pain, stiffness, swelling, fatigue. Now, the rheumatologist just diagnosed Rachel with lupus and then prescribed an immune suppressing medication. So Rachel, even though she's having some difficulty at work and she knows that she needs help, she read about some of the side effects from this medication that she was just prescribed, and she wants to know if there's anything else that can be done. So where do you start? Well, as every good doc does, you take a history and you find out that Rachel has been overweight since childhood, but she's had an increase in weight over the past couple of years. When she was a teenager, she had a pretty severe case of acne, and she ended up taking tetracycline for over a year. She did have postpartum depression after the birth of her child, and she was recently diagnosed with type 2 diabetes, and it's not really well controlled. Her family history doesn't look so good either. Her mother is obese, has type 2 diabetes as well, and some sequelae from that with peripheral neuropathy. Her dad is overweight, he's hypertensive, and he had a bout of prostate cancer. And her maternal grandmother also has rheumatoid arthritis, another autoimmune disease. and her sister is overweight and has polycystic ovary syndrome. And then there's environmental antecedents, right? So she has the genetic antecedents in her family history that are pretty clear. And the environmental antecedents, she was bottle fed when she was a baby. She's eating that standard American diet all through childhood, right? So she knows about diet. She knows that diet is important, but she's not really sure what to do. You know, she eats fast food around 4 times a week. She doesn't really like green vegetables, so she eats primarily corn as her vegetable. She counts that as a vegetable. And she doesn't like fish or seafood either. And the only fruit she eats are apples and bananas, and she sporadically eats them when she's able to pack her lunch. So, you know, this is the type of diet you see a lot of our patients eating in our really hectic world. So take a look at, this is Rachel's diet diary, okay? So as you know, a good functional doc, we really want to take these diet diaries, take a look through it, and you can even do this in the chat. Just start to see what are some of the things that might be inflammatory, pro-inflammatory in her diet, and any things you might see that are anti-inflammatory. And we're going to come back to this later and see how you did. So her social history, you know, she works 50 hours, 60 hours a week as a warehouse supervisor. She's a part-time caretaker for her mom, which you saw, you know, we saw earlier, has a lot of health issues. And she went through a very stressful divorce a couple of years ago. You know, she has 2 children. She's trying to put one of them through college. She doesn't have any close relationship. She does have a supportive circle of friends, but social outings are infrequent. And you know, she's just too busy with her work and her caretaker responsibilities. So, you know, we know that stress, in addition to diet, plays a really important role in our overall, you know, autoimmunity and inflammation. So really that bottom of the matrix. Sleep and exercise, also part of the bottom of the matrix, which Dr. Salt's going to go into more over this module. She does walk a lot when she's working in the warehouse, but she doesn't really have any kind of regular exercise routine. She's never been into sports, so she's been pretty sedentary through her whole life. She says she's just too tired to exercise, and she sleeps poorly, you know, about 6 hours a night. So that becomes a vicious circle. You know, she's too stressed to sleep, and so she doesn't sleep, and then she's too tired because she's not sleeping to exercise, and that just keeps continuing for her, which is pretty common in a lot of people. Her labs are clear that, you know, she's overweight, she has insulin resistance and diabetes that's not well controlled, and she does have inflammation with that high hsCRP, as well as autoantibodies that are consistent with the diagnosis of lupus, and that low vitamin D really isn't helping either. So despite being on 2 medications for her diabetes, her blood sugar is still not well controlled, as we saw. She's taking ibuprofen and NSAID for the pain, and an SSRI, because when she first complained of fatigue a couple of years ago when she was going through her divorce, her doctor put her on the SSRI because she did have that postpartum depression when her son was born. Now, she is taking some vitamin D and some calcium for her bones, but despite that, we saw that her vitamin D level was pretty low. And she's taking this drugstore brand multivitamin, so she doesn't think she has any kind of nutrient deficiencies. So we can map Rachel's history onto the timeline. And as we do that, it starts to become pretty clear why she suddenly caught autoimmune disease. Autoimmune disease doesn't happen overnight. You know, so again, in the chat, throw out some reasons why, as you look at her timeline, she might have been diagnosed with lupus right now. And then we can map all of that onto the matrix. And we start to look at where our biggest point of leverage. There's quite a lot of ink on this matrix. So quite a lot of places we can start. You know, if we look at the bottom of the matrix, there's stress and there's sleep, but diet is definitely one that we need to address. So what should we do with Rachel's diet? So hopefully we're going to cover these right now. So let's look at our first objective. And what's the evidence of diet and how it can impact inflammation? And as we go through, keep Rachel and her diet in mind as we go through this. So as with breakfast, and in our case, lunch, let's get started. So foods can inhibit or cause inflammation through a lot of different mechanisms. And many of these mechanisms are overlapping or synergistic. They can affect the microorganisms in the gut and result in the translocation of LPS, which we know is very inflammatory. They can affect the composition of cell membranes, which are the building blocks of these inflammatory mediators. They can dampen certain inflammatory pathways, these extracellular and intracellular transcriptional pathways, and they can activate certain counter-regulatory pathways. So foods in our diet can do a lot of things. They can also affect the eicosanoids that are made from different fatty acids in our cell membranes. The type of fatty acids that we eat will also affect that composition of the cell membranes and what's then made. They can affect oxidative stress, both by causing it and by providing antioxidants. They can affect various inflammatory and anti-inflammatory cytokines like TNF-alpha. Food can affect inducible nitric oxide synthase, as well as different transcription factors like the PPARs, or peroxisome proliferator activated receptors, and nuclear kappa B. And they can also influence inflammasome activation. So foods act in a lot of different places. Let's look at one that I know you've heard already about, but the NF-kappa B, it's an important transcription factor, and this is why we keep coming back to it and bringing it up. It really is one of the, not the only one, but one of the central players in the inflammatory response. And when it's activated, NF-kappa B binds to DNA, and it turns on the transcription of a number of genes that are involved in the inflammatory response. And some of these are actually products that go back and increase inflammation, creating a vicious kind of feedback loop of more and more inflammation. So NF-kappa B is one of the key pathways. It's not the only one, as we've seen and we will see, but it's one of the key pathways involved in the inflammatory response. Now, one of the things that we have to keep in mind, that even though NF-kappa B, drives inflammation, nothing in our bodies is all good or all bad. And that's the same with NF-kappa B. We actually need NF-kappa B and inflammation, obviously, to heal wounds and to fight infections. But genes that have NF-kappa B binding sites actually have increased expression during learning and brain development, suggesting that these targets for NF-kappa B in the nervous system are really important for brain plasticity. And one of those genes is the brain-derived neurotrophic factor. So just keep that in mind. We don't want to vilify anything. We want to understand its role in the overall immune system. So in order to control inflammation from NF-kappa B, a lot of pharmaceuticals have been developed and are used to really block all of these different types of things that come from NF-kappa B activation. So remember that when a drug is developed, they do develop it to target a very specific pathway. And so we look at the pathway. For example, the biologics are a really good example of this. TNF-alpha, we know, drives inflammation. So a lot of products are screened for their ability to inhibit TNF-alpha. And really, it's the ones that bind the strongest and bind irreversibly that are chosen to be the drugs. They pass all of those screening tests. So the stronger the binding, the better the drug is considered to be. Now, this will definitely dampen the inflammatory response, but as we've just seen, we need some NF-kappa B. We need a little bit of inflammation. Shutting it off completely is really not the best way to go. But foods, on the other hand, not like drugs, they don't irreversibly inhibit NF-kappa B. They actually modulate it, and they modulate the immune system. So these different nutrients, as you can see, the omega-3 fatty acids, the catechins, the curcuminoids, zeaxanthins, those are all act synergistically with each other to balance that inflammatory response in the immune system. So these are all agents that can inhibit or modulate NF-kappa B. So the drug glucocorticoids, we know, do that. But dietary interventions like calorie restriction, fish oil, alpha-lipoic acid, N-acetylcysteine, and vitamin C and E all inhibit NF-kappa B. Same with the spice-derived phytochemicals, right? Turmeric, rosemary, ginger, cinnamon, garlic. They all decrease inflammation by modulating NF-kappa B. different flavonoids like quercetin and from grapes and apples, resveratrol, green tea catechins. I'll be sipping my green tea partly throughout this talk. They all modulate NF-kappa B as well, and same with the elagitannins, ellagic acid from pomegranate juice or pomegranates, that actually gets converted by the microbiome into urolithin A, which is the inflammatory, anti-inflammatory component. And we're going to look at the microbiome's role in food a little bit later. So in addition to NF-kappa B, we now understand that the inflammasome is also a very important mediator of inflammation and the whole inflammatory response. So it shouldn't come as any surprise that an antioxidant poor diet really low in antioxidants, can activate the inflammasome. And stress also activates the inflammasome. It's interesting to note in this age of our pandemic that the NLRP3 inflammasome is the one that gets hijacked during a COVID-19 infection. So thinking about what effect diet might have on this inflammasome makes a lot of sense right now. Just to remind everyone, the inflammasome activation starts when different pattern recognition receptors are bound by the PAMPs and the DAMPs, which then cause a variety of these different cytosolic proteins. They all start to assemble, forming the inflammasome. Ultimately, that turns on capsase 1, which then cleaves the pro-inflammatory cytokines, pro-IL-1 beta, pro-IL-18, into their active forms. Now, many of these natural compounds, and we'll see this a little later, from foods can dampen that inflammasome response. So plants have been popular sources of pain remedies in just about every culture on earth for thousands of years. And that's because they work. And they work by modulating inflammation through synergistic actions on a lot of different pathways. So food does really matter. How many of you had a lunch that looks like this? Food is information. Food informs our genes, and it modulates and balances many different pathways. So we can use foods like this, or we can use foods like this to send messages to your body. As you saw, Dr. Roundtree went over this talk earlier, or this particular study earlier in his talk, that a single high-fat, high-carbohydrate meal can cause inflammation. Now, one of the things to keep in mind is that it's not just a high-fat, high-carb meal that they're testing. This is also a meal that's highly processed. So keep that in mind when we interpret some of these. There was a more recent paper published, about 3-4 years ago now, that showed that consumption of high saturated fat meal, but not a high monounsaturated fat or a low-fat meal that was high in complex carbohydrates, increased serum LPS levels, leading into this huge inflammatory response. So it's the type of fat, the type of carbohydrate really does make a difference. And you can think of this as a different form of predation, the ancient versus modern predator. So let's take a closer look at some of these mechanisms that diet can either cause or inhibit inflammation. And let's start by looking at the glycemic load. So this was an important paper that looked at the direct relationship between glycemic load of the diet and inflammation, which was measured by hsCRP. So CRP, as you know, is one of the best markers we have to really get a sense of systemic inflammation. And a lot of studies use CRP as a marker. And it's also strongly associated with an increased risk for cardiovascular disease. So this paper showed that CRP is significantly associated with a high glycemic load. So lowering the glycemic load in the diet lowered those conventional risk factors for cardiovascular disease. Now, it's really interesting to note, this is the same study, that the association between glycemic load in their diet and CRP levels was significantly modified by the person's BMI. So those that had a higher BMI had a greater increase in CRP levels with the same glycemic load diet than those with a normal BMI. So the higher the glycemic load, the higher the CRP, and the heavier you are, the more significant that relationship is. So the same high sugar meal will have more of an inflammatory effect the more overweight you are. Now, this study shows that the glycemic load of a diet affects inflammation independent of whether someone loses weight. So the glycemic load isn't all dependent on whether it causes weight loss. So this study had two diet groups, one with a high and the other with this low glycemic diet. And both diets were designed so that nobody lost weight. The low glycemic group had lower CRP levels, higher adiponectin, and none of the groups lost weight. So it shows us that the glycemic load and not just weight loss is really that inflammatory trigger. Now, a critical thing to note is that the decrease in inflammatory markers only happened in the overweight group. In the normal weight group, there was no change in CRP. So it's important for everyone to eat a lower glycemic diet, but if you're overweight, it's even more important. So this connection with glycemic load and inflammation likely involves a lot of different factors, decreased oxidative stress, decreased insulin resistance, improved lipids, decreased hypertension. And these are all factors that, of course, are worsened with increased weight and adiposity. High blood sugar, though, also leads to this non-enzymatic glycation of proteins and lipids, which we call AGEs, right? Advanced glycation end products. So when we have high blood sugar, the sugar then binds to the proteins and lipids that are there. And these AGEs, so these glycated proteins, can then bind to RAGEs. Now, RAGEs are a type of pattern recognition receptor. So they're the receptor for AGEs. And remember, pattern recognition receptors are DAMPs and PAMPs. So these glycated proteins are really seen as damage in our body. Now, when these AGE receptors are activated, when they bind the AGEs, it really turns on a significant inflammatory response. And we see that RAGEs are upregulated in chronic inflammations. That's another reason why glycemic load plays a big difference and why people with insulin resistance and diabetes have higher amounts of inflammation and risk for autoimmune disease. So we know we want to lower the glycemic load of our diets and work on decreasing that amount of sugar. Let's turn to oxidative stress now. We know that oxidative stress is a trigger for the inflammatory response because it causes these damage-associated molecular patterns, right? It damages, just like the glycation does, it damages the proteins and the lipids. And we know that our diet provides us with a lot of antioxidants. So a diet high in antioxidants should decrease those inflammatory triggers. And that's what all the studies actually show. Now, this was a population-based prospective study with more than 25,000 people. And they looked at a diet diary, and then they identified new cases of polyarthritis. Now, when they measured the diets, even a small increase in beta cryptoxanthin, which was equivalent really to just one glass of orange juice a day, reduced the risk of inflammatory disorders like rheumatoid arthritis. So the lower risk of arthritis was associated with zeaxanthin and beta cryptoxanthin, but not the more well-known ones, leucopene and lutein. So really keep in mind that it's a multitude of different types of phytonutrients that are important, right? Not just the ones that we find in our vitamins and our prepackaged pills. So these are all foods that are really rich in that zeaxanthin. Now, this was a study done with over 2,000 people, and they were followed for over several years. And it showed that a dietary pattern that was high in vegetables and vegetable oils that led to high intakes of those antioxidant micronutrients and essential fatty acids, which you heard about and we're going to go into again, was significantly and negatively associated with a risk of elevated CRP, especially when that was compared to dietary patterns that were low in those vegetables. Again, this is a consistent finding. This dietary pattern of high vegetables is seen in pretty much every dietary study. So an antioxidant we know a lot about is vitamin C. Now, vitamin C can have significant effects on reducing CRP levels. Now, it seems to work both when taken in foods and when taken in supplement form. So this was a study, and they looked at total levels of plasma vitamin C, and the levels of the vitamin C in the plasma were correlated with lower CRP and these other inflammatory cytokines. And when they supplemented with big doses of oral vitamin C, it also reduced CRP, especially in those that they used people that were at high risk for cardiovascular disease. Now in smokers seems to lower the level of vitamin C in people's blood, which makes sense. I think they're using up a lot of it. But what's surprising is that plasma levels of vitamin C were not always correlated with dietary intake. So one of the reasons for that could be because, people either use up the vitamin C or that we have genetic variations in our ability to absorb vitamin C in from our diet. And these variants are called these solute transporters. So something to keep in mind, that we're all going to have different variants in our ability to absorb. Okay. Now, one of the clinical pearls in this particular study, they actually used serum alkaline phosphatase as an indirect assessment of ascorbic acid levels. Now, sometimes it's the simplest things that can have significant and additive effects on this inflammatory process, right? Such as just some basic nutrients in the form of multivitamin. Now, you're going to hear me say a lot that food is more important than vitamins, and that there's a lot of compounds in foods that we don't put in our vitamins, like the zeaxanthin and the cryptoxanthin that I just mentioned. But it's nice to know that just a simple multivitamin replacing that can also have a good effect. So these vitamin C levels, as I just said, were associated with lower CRP, but there was also this inverse relationship of these inflammatory markers and fruit intake, even after you adjusted for CRP. So obviously there's more than just the vitamin C. There's a lot of other nutrients that you get from eating the fruit, just kind of what we were talking about. So this study again supports that, right? The idea that you use real food showed that there's this strong correlation with fruit and vegetable intake and low plasma CRP. Also lower incidence of metabolic syndrome. So, it's always best to start with food and think of supplements as just that. They supplement, they're not replacements for starting with that whole food. So let's look at the next mechanism, the modulation of signal transduction pathways. This brings us to the field of nutrigenomics. And a lot of times there's some confusion between nutrigenomics versus nutrigenetics. Nutrigenomics looks at how food affects the expression of our genes, while nutrigenetics looks at how our genes affect the foods we eat. So those solute transporters, or the way we absorb vitamin C, that would be an example of nutrigenetics, while nutrigenomics are things like foods turning on the expression of NF-kappa B. So food really is information, right? It contains information that controls what genes are expressed. So you can really think that you are what you eat. So we've talked about NF-kappa B, this whole signaling pathway, lots of times, and how it's implicated pretty much in all types of inflammation. So there is a lot of research being done. But again, keep in mind that not all NF-kappa B is bad, and we don't want to irreversibly inhibit it. So it turns out that all of these foods listed here, you can see there's a lot of foods, the components of foods, as well as certain supplements that actually decrease the binding of NF-kappa B. But they do that in a reversible manner, right? They modulate the NF-kappa B. And it's no surprise that all of these compounds are found in diets that are rich in fruits and vegetables and spices. So if you're wondering what foods contain these NF-kappa B modulators, the resources are there in the toolkit. And I really encourage you to use your toolkit. There's so many just wonderful resources for you. This list in this particular case, that whole phytonutrient spectrum, you can print these out, you can send them to your patients. It's a really nice resource to have and to use for your patients. And as we talked about, that inflammasome activation, just to remind you, that's another central player in the whole inflammatory response. And there are a lot of foods that also modulate inflammasome activation. Green tea, and that's what, like I said, I'm drinking that EGCG right now. Curcumin from turmeric, so the spices have it. Resveratrol, quercetin, sulforaphane, even honey has a lot of that anti-inflammatory compounds in it that can decrease inflammasome activation. So there's another transcription factor you may have heard of. It's called NRF2. Now this one is one of the good guys, right? So it actually, when NRF2 is turned on, it actually turns on the expression of antioxidant genes. So even though we talk a lot about getting antioxidants from our diet, really the majority of antioxidants are actually made by our body, because we need to combat all those free radicals that are produced just from living and breathing and making energy. And so our body has a lot of those, obviously, just to stay alive. So just like NF-kappa B, if we think about NRF2, it's kept inactive in the cytosol. So you have by KEAP1. So KEAP1 and NRF2 are bound together in the cytosol. And when it's activated, the KEAP1 disassociates, the NRF2 goes into the nucleus, and it binds to these AREs, or what we call these antioxidant response elements, which it turns on. And a lot of the anti-inflammatory genes have these antioxidant response elements that get transcribed and turned into protein. So one of the really powerful ways we have of seeing the effect that a gene has is by, unfortunately, using poor mice, but we can delete that gene in mice and then see what happens. So when NRF2 was deleted in mice, they actually developed an autoimmune disease that was very similar to lupus in humans. So it really shows how important NRF2 is in controlling inflammation and then subsequent development of autoimmune disease. And it's, these are all compounds that actually activate and modulate that NRF2 KEAP1 signaling. Again, you've got the polyphenols. Green tea, the EGCG from green tea shows up a lot as anti-inflammatory in pretty much all of these different pathways. The other polyphenols from curcumin and resveratrol and rosemary, again, those spices and herbs. And then the organosulfur compounds like the sulforaphane from broccoli and the allicin from garlic, they all turn on that NRF2 pathway. Now, it's interesting to note that some pharmaceuticals also turn that on, like metformin, and some of the statin drugs actually also turn on the NRF2 pathway. It may be one of the reasons they do work. But again, bringing it back to that concept of balance, right? It's all about balance. There's a common food additive called THBQ, and that can activate NRF2 in T cells. And when it activates them, it actually skews them to a Th2 response, which, as you know, really promotes that allergic response. And it's actually thought that this may be one of the compounds that's responsible for promoting food allergies in humans, these food additives. So again, keep in mind, nothing is all good or nothing is all bad, and it's all about context. It obviously, matters what activates that NRF2. We know that sulforaphane is a great NRF2 activator. That's why we see it in a lot of these NRF2 activating products, or they all contain some type of broccoli extract. But to illustrate this point, that a specific nutrient can have anti-inflammatory effects in lots of different ways, right, through different mechanisms. So we know that sulforaphane inhibits inflammasomes, and we know that it inhibits NRF2, but it does so separately, right? It doesn't have to go through NRF2. So sulforaphane has effects on multiple different pathways. The PPARs, or the peroxisome proliferator activated receptors, that's the last time I'll say it, we'll say PPARs, is another set of really important transcription factors, right? They're a group of, again, nuclear receptor proteins that, of course, do what transcription factors do, and they turn on the transcription of genes and then regulate their expression. So PPARs play this essential role in the regulation of cellular differentiation, development, metabolism of carbohydrates, lipids, proteins, and the ligands for them are fatty acids, or the eicosanoids, the metabolites from fatty acids, the prostaglandins, leukotrienes. Now, PPAR, there's a lot of different types of PPARs. There's PPAR alpha, gamma. PPAR alpha and gamma are actually the molecular targets of a lot of the marketed drugs, like the lipid-lowering fibrates. They target PPAR alpha. The anti-diabetic TZDs activate PPAR gamma. And now this is a really active area of research. There's actually a whole journal dedicated to just PPARs. And you can see why, right? PPARs have a very profound effect, not just on the immune system, but really systemic, like on the whole body. And some of these are, you can see in the green, are kind of considered desirable when PPAR is activated. And others, you may argue, are maybe good, maybe bad, depending on how you look at it. So if you look at the brain one here, PPAR gamma activation can increase food intake, but it decreases inflammation. And depending on the context, increasing appetite may be a good or bad thing. So again, it's all about balance and context. The big paradigm shift, which I've told you already, was that when we found out about PPARs, it was that fatty acids can actually regulate gene expression. It's not just proteins that regulate gene expression, which is what we always thought, because these fatty acids act as a ligand to turn on PPAR expression. So that was a really big paradigm shift when we learned about that. Not only are fatty acids important as precursors for the inflammatory and anti-inflammatory eicosanoids, but they also control gene expression. And again, a lot of people have different genetic SNPs in their PPARs. So a lot of people will have very individual responses. So that kind of segues into the types and balance of the fatty acids. Now, this is an image I know that Dr. Fitzgerald just walked you through, so I'm not going to go into detail here, but I really want to stress the importance of this diagram. I have it sitting here laminated on my desk because I refer to it a lot. I think it's really important. And just as a hint for those of you going for your certification, this is one thing you really want to have handy or know about. So just to remind you, the omega-3 is on the left, the omega-6 is on the right. And you can see that arachidonic acid and omega-6 is a precursor to inflammatory prostaglandins and eicosanoids, that EPA is a precursor to the anti-inflammatory ones, the fish oils, right? And that EPA inhibits delta-5 desaturase, which will lower the amount of arachidonic acid made. And that if you intake more omega-3s versus omega-6s, since they all share the same enzymes, you're going to have more of the anti-inflammatory EPA. So today I ate 2 bowls of dog food, a sandwich crust, some spaghetti that fell on the floor, half of your cat food, a wet tea bag, 3 bugs in the inside of a sneaker. So how many grams of fat is that? Hopefully your lunches weren't quite like that. So we just mentioned that arachidonic acid are metabolites that are, the metabolites of arachidonic acid are usually quite inflammatory. And this paper does, confirm that. It's pretty clear that arachidonic acid is a mediator of inflammation. Again, remember that arachidonic acid metabolites also involve resolvins, which work to limit the inflammatory response. So again, not everything is all good and not everything is all bad, but as a rule of thumb, decreasing the amount of arachidonic acid, not to 0, but decreasing it will help to control inflammation. Now, in this study, they had 68 patients with rheumatoid arthritis, and they put them into 2 groups. One with an anti-inflammatory diet that provided arachidonic acid intake of less than 90 milligrams a day, or a traditional diet high in arachidonic acid. Now, both patients were then allocated to receive either a placebo or a fish oil, for 3 months, and they did this in a blinded crossover study. Now, in the autoimmune, or sort of the anti-inflammatory diet, or you call it an autoimmune diet as well, the numbers of tender points in their joints really decreased quite significantly. And then when they added fish oil to it, it led to an even more significant reduction in these number of swollen joints. So it's really interesting that fish oil actually augmented the beneficial effects of an anti-inflammatory diet, or you can think about that vice versa as well. So omega-3s in the diet are not just as a supplement, but also as food, right? Even eating 600 grams of Atlantic salmon, which gives about 1.5 grams of EPA DHA, it really decreased the scores of inflammation and the symptoms of ulcerative colitis. So you can think of 1.5 grams. That's really a lower amount than we typically use when we give a supplement, right? We give it in 3, 4, even higher amounts, but it still works. So it may be that the other compounds in the fish really had a synergistic effect with the omega-3s. So it's not a new idea, the idea of using fish oil, right? In the late 18th century, it was Sir Thomas Percival he recommended 1 to 3 tablespoons of cod liver oil 2 to 4 times a day to treat obstinate chronic rheumatism, sciaticas of long-standing, and in those cases, a premature decrepitude. So it's kind of a fun quote to read, but we knew that fish oil made a big difference for a long time. So what should the ratio of omega-6 to omega-3 fatty acids be? We know that you need both, so the ratio is important. Well, there's been quite a few studies. You know, there was one showing that a ratio of 4 to 1 was associated with a decrease in mortality. A ratio of 2.5 to 1 reduced rectal cell proliferation in colorectal cancer, but 4 to 1 didn't work. A ratio of 2 to 3 to 1 suppressed inflammation in patients with rheumatoid arthritis. 5 to 1 had a beneficial effects on patients with asthma. So the optimal ratio, you know, if you summarize all of the studies, and I know there's a bit of debate about it, but it's really around 4 to 5 to 1 seems like a reasonable goal to get our patients to do. So what about trans fatty acids? Now, this particular study, trans fatty acid intake was correlated with increased TNF alpha receptors in all women in the study, and that it also was associated with an increase in IL-6 and CRP in obese women. So again, you know, obesity tends to exacerbate the negative effects of food. We see that with glycemic load. We see it with trans fatty acids. And margarine was the worst of all of them in increasing those inflammatory markers. So this is a nice summary slide for you to kind of refer back to. Arachidonic acid is a precursor to inflammation. The omega-3s is the precursor to the anti-inflammatory eicosanoids. EPA blocks that production of arachidonic acid, and by consuming more omega-3 to omega-6, you shunt things over to that omega-3 pathway. And then don't forget that all of those enzymes, they need the cofactors, all those desaturation enzymes. So the zinc, the magnesium, the vitamin C, those are all cofactors for those enzymes. And then the trans fatty acids, they're just bad. What about fiber? That's the last, but definitely I would say not the least one on our list. Now, dietary fiber is very protective against high CRP. This is true when you look at either soluble fiber or insoluble fiber, and it's seen in cross-sectional studies, longitudinal analysis. I have not found one study where there's a negative effect from consuming fiber. So the fiber is very anti-inflammatory, and it's consistent across the board, no matter what study you look at. So this one looked at CRP, soluble, insoluble, as I was mentioning, and you see it linked to decreased mortality, decreased infections, decreased inflammation, decreased respiratory diseases. It's really, I don't think I can stress how important it is. This is a really nice summary table of some of the studies that were done that look at the beneficial effects of fiber and the anti-inflammatory effects. So if you look at this second study here, even in infants, adding fiber to 6-month-old infants decreased the number of infectious episodes. And if you look at adults, you know, obese adults, diabetes, people with high cholesterol, the elderly, those with ulcerative colitis, in every single case, adding fiber to their diet would increase the regulatory cytokines and decrease the inflammatory cytokines, and really end up resulting in decreased disease activity. So remember how the inflammatory response is exacerbated in obese individuals, right? That adding fiber to their diets will not only help them lose weight, but it reduces their inflammatory response quite significantly. Now, this table shows the recommended amount of fiber in different countries throughout the world. You can see that in the US and Canada, our recommended fiber intake is 38, whereas most people get around 16 grams of fiber a day. And in other countries, you can see really in no country, maybe Germany, they come a little closer, in the UK to meeting their requirements, but ultimately most people do not get enough fiber. And then when you put those recommendations into context, if you think about African Americans, if they would have traditionally eaten about 55 grams of fiber, you can see that in traditional South African populations. And if you add that amount of fiber to African Americans, they actually improved their mucosal biomarkers and reduced their colon cancer risk in just 2 weeks of adding that extra fiber. So I think though, even though our guidelines say, 38 grams of fiber, I think the recommendation should be even higher than that. And if you can get people up to 50 grams of fiber, I know it seems like a lot, but that's going to go a huge way into decreasing inflammation and really supporting their microbiome, which is how it works. And if you think about our ancestors, or if you're in the paleo world, the ancestors really ate at least that much fiber, if not more. So how does fiber produce this, amazing anti-inflammatory effect? Well, it decreases the risk of obesity. Clearly, if you eat the fiber, you're not eating other things that cause weight gain. But it's also in and of itself inflammatory, right? It feeds our microbiome, and then our microbiome modulates our immune system, either directly at that level of that gut interface, or indirectly by promoting the production of these short chain fatty acids, which then go on to